Hello and welcome to the third day of the European Congress of Rheumatology 2021. We really hope you're enjoying the Congress and thank you for joining us on the third and final day of EULAR News. My name is Mrinalini Day. I'm an academic clinical fellow and rheumatology registrar training in Liverpool in the UK. And today, as ever, I am joined by my co-host, Tu Kagsrup. Tu, how are you doing today?
I'm good. Hello, Mrinalini. Very excited to see you again.
You too.
So my name is Tu Kagsrup. I'm an associate professor in immunopharmacology at the Department of Biomedicine at Aarhus University, and I'm also MD and training in rheumatology, currently at the Department of Rheumatology at Aarhus University Hospital in Denmark. So the focus of my part of the report today is new drugs in psoriatic arthritis, and then it will be side effects of JAK inhibitors.
Great. And later on, I'm going to be covering some of the oral abstracts from some of my favorite topics, so epidemiology and also new developments in COVID research. But just moving to another area, which is very close to my heart, which is on comorbidities and difficult to treat rheumatoid arthritis. So this session took place just after lunchtime today. So the background to this is that the EULAR definition for difficult to treat rheumatoid arthritis was published only a few months ago in the Annals of Rheumatic Diseases. And this series of presentations today was a very useful way to delve deeper into this topic and hear from some of the authors.
So comorbidities are really important in the context of difficult to treat RA. Did you hear anything on this?
Yes, absolutely. So Dr. Elena Nikiforou spoke to us about the role of comorbidities in difficult to treat rheumatoid arthritis. I particularly enjoyed this talk because it gave a really good background to the concept of comorbidity in general, which is of course a very important topic in the context of rheumatic diseases overall. Comorbidities are particularly relevant in difficult to treat disease, and this has been demonstrated in multiple large studies. This can lead to outcomes such as hampering proper grading of the disease, inappropriate treatment decisions, and can reduce effectiveness of medications. So it's really important to address these comorbidities and recognize them early so we can prevent adverse disease outcomes. Dr. Nikiforou also highlighted the need for patient-centered care, which is tailored to individual needs, as well as risk stratification for patients with multimorbidity and difficult to treat RA. So elsewhere in inflammatory arthritis, Tu attended a presentation on the treatment of psoriatic arthritis and TNF inhibition.
Yeah, so the first two talks I want to highlight are from the session called Psoriatic Arthritis Treatment. So as you mentioned, both studies assess what happens in patients with inadequate response to TNF inhibition. So the first was oral presentation 0230, and this was titled Efficacy and Safety of Guselkumab in patients with active psoriatic arthritis who demonstrated inadequate response to tumor necrosis factor inhibition, week 24 results of a phase 3b randomized control study. And this was presented by Professor Laura Coates. So guselkumab is a selective monoclonal antibody targeting the interleukin-23 P19 subunit. And this drug class has shown great efficacy in psoriasis skin disease and is now emerging also as a great option for PSA.
Great. And in fact, guselkumab has already demonstrated efficacy in 2 phase 3 PSA studies.
Yes, exactly. So this study evaluated specifically the efficacy and safety of guselkumab in PsA patients with an inadequate response to TNF inhibition. So this was 255 patients with active PsA with at least 3 swollen and tender joints. The primary efficacy endpoint was ACR20 response at week 24. And just overall, guselkumab was effective in patients with inadequate response to TNF inhibition. So ACR20 was achieved in 44% in the guselkumab group and in 20% in the placebo group. So we already know that P40 inhibition with ustekinumab is established, and now P19 inhibition is also establishing as an effective mode of action in PSA. And this sort of brings me to the next study. So this is all presentation 0227, and this is titled Efficacy of Crevacity, an oral selective tyrosine kinase 2 inhibitor in musculoskeletal manifestations of active psoriatic arthritis in a phase 2 randomized double-blind placebo-controlled trial. And this was presented by Professor Philip Mies.
Yes, so I think this begs the inevitable question, do you crave another Citinib?
Exactly. So the name is a bit interesting. So Crevacity is a novel oral selective inhibitor of TYK2. So TYK2 is of particular interest in PSA because TYK2 is one of the intracellular kinases that mediates IL-12 and IL-23 signaling.
So quite a novel target then.
Yes. And this was a pre-specified subgroup analysis from a phase 2 trial assessing the likelihood of achieving ACR20 response at week 16 based on study stratification factors. And the main finding was that patients treated with Crevacity were more likely to achieve ACR20 response compared with placebo-treated patients, regardless of TNF inhibitor experience. So obviously this is a small study and only around 30% of patients had been previously treated with a TNF inhibitor. So further studies are obviously needed with patients with inadequate response to TNF inhibitors. So Arlene, you obviously went to the epidemiology session.
Yes, I did. So I'd like to highlight one abstract from the epidemiology session. So this is oral presentation 0241. On serious infection risk associated with tocilizumab and the impact of line of therapy in this. So the aim of this study was to evaluate if and how the risk of serious infection on tocilizumab and other biologics differs when stratifying by line of therapy in patients with rheumatoid arthritis. The group found that compared to etanercept, patients starting abatacept, tocilizumab, and rituximab were older, had more previous biologics, longer disease duration, and more comorbidities. Adjusted hazard ratios of serious infections were higher with tocilizumab, adalimumab, and infliximab, but when stratified by line of therapy, hazard ratios were no longer significantly different compared to etanercept for all three drugs for most lines of therapy. So line of therapy may be a confounding factor when comparing the risk of serious infections between biologics. So infection is an important side effect of immunosuppression. And of course, yesterday we discussed infection risk with JAK inhibitors. And today, Tu attended a talk by Roy Fleischmann on the overview of side effects of JAK inhibitors. And I'd love to hear more about that, Tu.
Thank you. This was my favorite talk from today's program. It was a talk from the session TSD-MART therapy of rheumatoid arthritis, and this particular talk was called JAK inhibitors in the news, side effects. And it was, as you said, presented by Professor Roy Fleischmann. So Professor Fleischmann starts with the very important but also a little bit controversial statement saying, if it is not safe, efficacy is not important. And I find this talk so important because giving an overview of JAK inhibitor side effects is very difficult at the moment. So we have a press release from the only long-term safety data in high-risk patients with JAK inhibitors, and this is for tofacitinib, obviously. And we will likely not get these data for baricitinib before 2024 or even later, and definitely even later for the other JAK inhibitors. So careful interpretation of tofacitinib data is crucial at the moment. So we already sort of have drug agency decisions on BTE. So the focus of Professor Fleischmann's talk was on malignancy and on major adverse cardiac events, also called MACE. So Professor Fleischmann starts with integrated safety analysis of all the approved JAK inhibitors, that is tofacitinib, baricitinib, upadacitinib, and filgotinib. And importantly, here the numbers of malignancies and MACE are just almost the same for all the JAK inhibitors. And this is just the context for interpreting the oral surveillance study. Here, as you probably know, the primary endpoint of non-inferiority of tofacitinib compared with TNF inhibitors for malignancies and MACE were not met.
So did we get any recommendations about how to use JAK inhibitors?
Yeah, so obviously many unanswered questions relating to the oral surveillance study, because it's only out in press release. Also many unanswered questions about how to handle the other JAK inhibitors. But Professor Fleischmann ended his talk with a very useful slide about who should not be treated with a JAK inhibitor. And he lists that until we sort of know more, he recommends holding back JAK inhibitors in patients with one, a high risk of PE or VTE, especially past history. Also, some reluctance about high risk of MACE and malignancy, so that could be older age and smoking, and also documented history of diverticulitis. So the final highlights come from a session on new developments in COVID research.
Yes, so this oral abstract session was on the latest research in COVID, and also covered a wide variety of topics, including 2 abstracts, so oral presentations 0282 and 0284, on severity of COVID infection in patients taking rituximab. Now, both presentations highlighted the increased risk of severe COVID-19 in patients taking rituximab, with the suggestions that those receiving rituximab should be prioritized for COVID-19 vaccination before infusion or reinfusion with the drug, and the immunization status actually checked, or consideration of an alternative medication in these cases.
Anecdotally, I have seen a rise in GCA presentations during COVID. Any abstracts on this?
Yes, actually as well. So oral presentation 0281 was on the numbers of presentations of cases of giant cell arteritis, or GCA, and the association with COVID-19 prevalence. So I was really looking forward to hearing this talk, actually, because I've also noticed in my clinical practice that a relatively greater number of patients appear to be presenting with symptoms of GCA during the peaks of COVID-19. So the aim of this study was to estimate the incidence of GCA during the COVID-19 pandemic during 2020 and 2021, as compared with 2019. So the authors found that in their locality, the incidence of GCA significantly increased in 2020 compared to 2019. And it was suggested that this may be due to widespread COVID infection in the local population as a precipitating factor. Now, the exact mechanism for that still remains unknown, but could be due to, as the authors suggest, due to endothelial disruption or immune system priming towards Th1 cells, cellular immunity, or activation of the monocyte macrophage system. So those are our highlights from day 3, but I believe that Tu wants to highlight some talks which are coming up tomorrow, because of course the Congress hasn't finished yet. So what are your highlights for tomorrow, Tu?
Yeah, thank you. So first, I look very much forward to the session titled, "Is Early Treatment of RA Better Than Wait and See?" And especially the talk by Professor Annette van der Helm van Mil, called "Arthralgia of Recent Onset with Positive ACPA and Synovitis at Ultrasound. What is the diagnosis and how should we treat this patient?" And the other session I look very much forward to is called "RA Treatment, Educated Choice or Educated Guess?" And especially there's an interesting talk called "Should Superiority Trials Be Used to Change the Guidelines?" And this is to be presented by Professor Daniel Aletaha.
Yes, it was a really great session, and I'd like to highlight one abstract from there, which is oral presentation 0241. And this was on serious infection risk associated with tocilizumab and the impact of line of therapy on this. So the aim of this study was to evaluate if and how the risk of serious infection on tocilizumab and other biologics differs when stratifying by line of therapy in patients with rheumatoid arthritis. The group found that compared to etanercept, participants starting abatacept, tocilizumab, and rituximab were older, had more previous biologics, longer disease duration, and more comorbidities. Adjusted hazard ratios of serious infections were higher with tocilizumab, adalimumab, and infliximab, But when stratified by line of therapy, the hazard ratios were no longer significantly different compared to etanercept for all 3 drugs for most lines of therapy. So line of therapy may be a confounding factor when comparing the risk of serious infections between biologics. So infection is an important side effect of immunosuppression. And of course, yesterday we discussed infection risk with JAK inhibitors. And today, Tu attended a talk by Professor Roy Fleischmann on the overview of side effects of JAK inhibitors. And I'd love to hear more about that too. Thank you, Tu, for joining me for the last 3 days.
Thank you, Mrinalini. Thank you very much.
All right, thank you. Bye.
Bye.